series. So without further ado, it is my pleasure as always to introduce to you our dear Dr. Sanjay Uppal, who is the current president of Nabicon. I think also congratulations are in order because he's just been appointed as the CEO of the Mohandai Oswal Hospital in Lithuania. He's the former head of department of Diana Medical College. So, Dr. Sanjeev Uppal, over to your very able hands, sir.
Yeah, very good evening to all present. Good evening from India and internationally, whatever the time is, good afternoon and good morning. So we have a few people joined us from USA also at the moment. So good morning to them. So this is the third such endeavor by National Academy of Burns in India. Since we are unable to conduct the CMEs on the regular basis because of the COVID situation, so we thought that we continue our academic endeavors by means of the online CMEs. This time we have with us few variety of speakers doing different things in burn. So we have not categorically kept it as a single topic this time. So I wish to thank at the outset the Urgo Medical for supporting our academic cause and giving us the platform and working for us for this kind of academic activity. So they are, as you know, the Urgo is already into the technology, developing some advanced dressings for the burn wounds. So today we are going to have three very eminent speakers, eminent as far as their scientific work goes, eminent as far as their positions in their medical colleges go, and also eminent as far as the National Academy of Burns go. First of all, we have three speakers. Dr. SMITHA SEGU will be with us. She's already with us. Dr. K. BOOPATHY is already with us. And Dr. NELLAIAPPAR is also with us from Chennai and Bangalore, these people. So let me give you a small introduction. Otherwise, they have kind of CVs which run into almost 109 pages, one and 106 pages and 89 pages. So it was a difficult task for me to concisely introduce them in 1 minute each. Please bear with me, speakers, because I am going to cut short your CV. The first speaker with us would be Dr. SMITHA SEGU. She'll be deliberating on the causes, classification, organisms, and treatment strategies in burn infections, and of course the prevention of burn infections. She is professor and head of the unit at the Department of Plastic Surgery in Bangalore Medical College and Research Institute. She trains 4 MCH students fellows every year. She was instrumental in, this is her major achievement, that she was instrumental in bringing the first skin bank in Karnataka to that hospital. And then she has a 50-bedded burns unit with 30-bedded as barrier nursing units called as Mahabodhi Burn Center, which is now almost 30 years old. She is the secretary of the Karnataka Association of Plastic, Reconstructive and Aesthetic Surgeons since 2015. And so we can say that Karnataka could not find any kind of parallel secretary to her or better secretary to her. And also recently at the Shimla conference, the Nabicon 2020, she was elected as the executive member for the National Academy of Burns. And she's as a very aggressive team leader. I could learn from her college that she opted for as the first leader to fight against the COVID and was a team leader for so much time. Currently, she somehow got exposed to one of her positive colleague, but at this moment she's negative. But as far as customary, she is on quarantine at home with her husband. So wish you all the best, Dr. SMITHA. Second, we have with us Dr. K. BOOPATHY, who is a former professor and head of the department and medical superintendent at Chengalpattu Medical College. His duties included the other administrative duties, a lot of them, and also the plastic surgery at Government Kilpauk Medical College, Madras Medical College, and the Stanley Medical College with a total of 33 years in Tamil Nadu government service at various hospitals. So here we have the person who has headed departments in almost all medical colleges in Chennai. At present, he is a professor and head of the department at the Institute of Research and Rehabilitation for Hand Surgery and Department of Plastic Surgery at Government Stanley Medical College and Hospital, Chennai. So he received an appreciation award from Kanchipuram District Collector for highest number of IOL surgery in 1996 from blindness control program under him. And then Dr. Bhoopathy presented research papers at several conferences and published more than 12 papers in national and international journals. He is also an IMA life member for 30 years and served as Treasurer, Secretary and President of IMA Kanchipuram. Besides this, he has a deep interest in treating burns, and his motto is whatever happens, he wishes to be with a burn patient and tries his best to save the patient. Then we have another very eminent plastic surgeon, a burn surgeon, Professor P. NELLAIAPPAR, who is medical superintendent currently at Stanley Medical College. MCH, he did his MCH from the Madras Medical College. You can see a very nice smile on his face. He supposedly meets everybody with a smile on his face, which is a very good gesture. He's a former assistant professor in the Department of Burns and Plastic Surgery in Kilpauk Medical College for 1 year, then worked at Stanley Medical College for 8 years, and then former senior consultant and professor in Government Multi-Speciality Hospital in Chennai, worked there for 3 years. And presently, as I mentioned, professor of the Department of Hand and Plastic Surgery in Stanley Medical College, Chennai. So his topic will be, he will be discussing on post-burn reconstruction of the head and neck. And because he has done extensive work on these post-burn contractures, was mainly discussing the neck as well as the head part or the scalp part here. With these three eminent plastic surgeons with us to discuss things in burn infections and post-burn reconstruction. And I'm told that we are almost more than 100 plastic surgeon, burn surgeon and general surgeons who have already joined us in this endeavor, this scientific meeting. So on behalf of the National Academy of Burns, India, I welcome you all to this endeavor, and without taking much time, allow the academics to begin. So welcome you all, enjoy, and you can put your questions in the chat box. As Mr. Emilio has already briefed, we'll try to answer as many number of questions as we can. The rest, of course, will be answered on email. So welcome you all. I'll hand over now to Mr. Emilio, our moderator for the day, to start the proceedings.
Thank you very much, Dr. Uppal. And yes, we are already around over 130 participants. And I see that we have even participants from all the way from Buenos Aires. So it shows how much the Burn Academy of India has a good standing all over the world. So without further ado, we move to our first speaker, Dr. SMITHA SEGU, to give her presentation to you all. Thank you very much.
Ma'am, you are able to see?
Yes, I am. Okay. Good evening, everybody. I'm Dr. SMITHA, and Dr. Uppal has very generously given my introduction. Thank you very much, sir. Next slide. So can we start? Okay. So I'll be talking on the following contents. What is the magnitude of the problem? How are burn infections classified? What are the organisms associated with these wounds? Which organs and tissues are more susceptible to infection? And what are the strategies for surveillance and control? Can you go back, please? In India, about 70 lakh people suffer from burn injuries, as we know, every year, and out of which 1.4 lakh are deaths. And primary reason for death after the first, can we move the
Which slide, ma'am?
1 second. Okay. Primary reason for death after the first 24 hours is sepsis and accompanying invasive infection. Most frequent clinical complications are pneumonia, cellulitis, and urinary tract infection. Next slide. What are the causes of infection in burns? A loss of protective barrier, thrombosis of the subcutaneous blood vessels, avascular bed, which is an excellent medium to support growth of microorganisms and which prevents penetration of systemic antibiotics, and alteration in the defense mechanism, which is a state of immunosuppression. Next. Next. And how do we classify these infections? First would be burn, wound, impetigo, and folliculitis, which is caused by bacterial colonization rather than an invasive infection. And the burn, wound colonization of less than 10 to the power of 5 organisms per gram of tissue. And no evidence exists that the infection is invasive. The next would be burn wound cellulitis, where erythema extends beyond what would be expected for the injury alone. Increased warmth within the area, pain, tenderness, advancing swelling or induration, and lymphangitis may be observed. Invasive infection, when you have high concentration of bacteria in the wound, there are new areas of necrosis in the unburned tissues, often accompanied by signs of sepsis, which needs urgent debridement and broad spectrum antibiotics. Antifungals when indicated. And then we have the systemic infection or sepsis, where generally it is more than 20% of TBSA large burns, where barrier function of the skin is compromised. There's profound immune response, there is hyperinflammation, immunosuppression, features of SIRS sepsis sets in. But as the pathophysiology of burns is unique, the standard criteria of SIRS and sepsis may be inadequate in this scenario. Hence, consensus conference in 2007 by the members of the American Burn Association determined the definition of sepsis for burn patients. And that is, next slide. At least 3 out of the following 7, if present, are criteria to define them as sepsis: the temperature of more than 39 degrees Celsius, progressive tachycardia, tachypnea, thrombocytopenia, hyperglycemia, inability to continue enteral feedings, and documented infection which is identified. What are the pathogenesis behind this wound infection? The burn wound initially is colonized predominantly by gram-positive organism, and then eventually antibiotic-susceptible gram-negative organisms within a week. And if the wound closure is delayed, patient becomes infected, requiring treatment with broad-spectrum antibiotics. Yeast, fungi, and antibiotic-resistant bacteria are also common now. Next slide. What are the sources of infection? The sources of infection could be patients surrounding at the time of the other patients which are at the time of injury, endogenously from the patient, or exogenously from the hands of medical personnel or fomites. Exogenous sources are colonized healthcare workers, colonized patients, which are the major reservoirs, contaminated hydrotherapy instruments, common treatment areas, water sources, contaminated equipment, mattresses, hands and apron of the healthcare workers. Bacteriology profiles, sorry, go back. Go back. Yeah, one slide. Next slide. Next one. Okay. Bacteriology profiles. Recent trends which are published in India are Pseudomonas is the leading bacteria isolated in many centers. Acinetobacter baumannii, Klebsiella pneumonia, Staph aureus follow as common isolated organisms. Surge in invasive fungal infection leads to increased mortality. Multi-drug resistance are very prevalent in recent studies. Pseudomonas is the most ubiquitous burn wound pathogen, most likely responsible for sepsis leading to burn-linked deaths. Sources are local environment, GI tract via translocation of endogenous gastrointestinal flora, and characteristic yellow-green color and a malodorous fruity smell. Treatment of choice has changed over the years from aminoglycosides to piperacillin tazobactam. Monitor for sign of nephrotoxicity and neurotoxicities, and prolonged use of these drugs are not recommended. Staphylococcus, with liberal use of broad-spectrum antibiotics, methicillin-resistant Staph aureus has become the predominant pathogen. Vancomycin has been the standalone treatment of these infections. New antimicrobials to tackle this are linezolid, tigecycline, daptomycin, penipristine, dalfopristin, and dalbavancin. Streptococcus is now easily eradicated with penicillins. Graft failure is a major complication with Streptococcus, especially the beta-hydroxy Streptococcus. Enterobacteriaceae, emergence of vancomycin-resistant strains are being seen, attributable to more liberal use of vancomycin during the recent years. And VRE is treated with the linezolid or penipristine, dalfopristin. Acinetobacter may lead to numerous opportunistic infection, enhanced capacity for transfer between patients because of its ability to survive in both the dry and wet conditions, as well as on both animate and inanimate objects are seen. Resistance patterns are carbamazepines, where imipenem and meropenem can be given, and colistin. And other common bacteria are enterococci, E. coli, Klebsiella, Enterobacter, Serratia, Proteus, most often causing pneumonia and urinary tract infections. Carbamazepines and fourth-generation cephalosporins are the drugs of choice for these infections. Coming to fungi and yeast, introduction of topical antimicrobials and liberal use of broad-spectrum antibiotics resulted in a surge of invasive fungal infection, which has caused to a higher death rate. Candida albicans is the fourth most commonly found pathogen in blood cultures from ICU patients. Invasive infection with molds such as Aspergillus has a very high mortality these days. Increasing resistance to conventional antifungal agents such as fluconazole, capsofungan, and echinocandin is a treatment of choice in these cases where they are resistant to fluconazole. Active non-candidial infection, voriconazole is the first line of treatment, and amphotericin B is a liquid formulation. Risk factors of our antibiotic resistance or receipt of antibiotics prior to the development of infection, which is very common in most of the centers, extended duration of hospitalization, previous hospitalization, invasive procedures, and advancing age. Timeline for common infections and pathogens after burn injuries is as follows. A urinary tract infection, bloodstream infection generally start later on after the second week. The skin soft tissue infection, infection with Staph aureus begins within the first 1 week. And from the third week onwards, you have antibacterial resistance because of so many reasons that I have already mentioned. Bloodstream and intravascular catheter infection, which is very common. Rates of catheter-associated infection and septic thrombophlebitis are as high as 57%. Bloodstream infection occurs more often in burn patient than in any other patient population. Often necessary placement of catheters near or through the wound in patients with extensive injuries occur because of no normal skin, arise primarily from burn wound contamination migrating to the catheter tip. Prevention is distance separating the point of catheter insection and the burn wound, which sometimes cannot be possible. Strict monitoring of catheter sites and frequent change of sites. How do we prevent it? Is appropriate care of the burn wound to minimize the extent of hematogenous seeding. Whenever possible, catheters should be placed through unburned skin, preferably at the sufficient site from the wound, like I said. Insertion site care of intravascular catheters placed through or near a burn wound presents a challenge as occlusive dressings cannot be used. So blood culture, catheter tip cultures, and appropriate antibiotics have to be monitored. Treatment of the insertion site with same antimicrobial as the surrounding burn wound should be done. Urinary tract infections are also very common. Hematogenous dissemination of bacteria and fungi is the cause. Risk factors specific to these patients are presence of perineal burns, increased length of time that patients require catheterization in the treatment of extensive injuries, and signs and symptoms of UTI may be present or obscured and burn patients' relatives to other conditions accompanying the injury. Removal of the catheter if possible. Systemic antimicrobial treatment to eradicate the infection can be tried as treatment. And aseptic techniques in insertion, removal, catheter care, early removal and routine urine monitoring could prevent these UTIs. This is another major concern, major trigger of septic deaths after burns. Organisms cultured usually are reflective of burn wound flora. Pre-existing lung injury or inhalation injury are the risk factors. Ventilator-associated pneumonia appearing greater than 2 days after intubation in patients who showed no signs of pneumonia before this time at all. Is a very common cause. Antibiotics started promptly with antibiotic selection modified when culture sensitivity results are available. Vigorous chest physiotherapy, postural drainage, and suctioning could be the treatment of choice. And how to prevent it is high frequency ventilation, permissive hypercapnia in patients on ventilator, deep breathing, suctioning, chest physiotherapy. And before going on for intubation, we can try the high flow nasal oxygen, which is being tried now in many centers. Next slide. And in the GI system, we can, GI tract serves as the chief source of infection and sepsis. Clostridium difficile, opportunistic pathogen, which is the worst in immunocompromised patients. Necrotizing enterocolitis, classic presentation of a high spiking fever accompanied by left upper quadrant pain can be seen. Broad spectrum antibiotics with activity against streptococci in both aerobic and anaerobic gram-negative bacilli should be administered. Strategies for management, strict infection control measures, constant wound surveillance with regular sampling of cultures, early excision of wound and grafting. Infection control can be done in these methods. Barrier nursing, nurse to patient ratio has to be perfect. Regular disinfection, surveillance of facility, segregation of the infected patients, and priority of dressings based on infection. Hand washing, thorough hand washing before and after touching anything in the cubicle. All members of the team must be responsible for enforcing the discipline of hand washing. Infection control items such as blood pressure cuffs, stethoscopes, bedpans, if used on areas without dry occlusive dressings, may need high-level disinfection. Plants and flowers should not be allowed in unit with burn patients because they harbor gram-negative organisms. Routine cleaning, disposable of waste, and gathering of soil linen is essential to reduce the bioload of organisms. Wound surveillance has to be done routinely. Clinical impression is very important. Qualitative findings from surface swabs are sometimes inadequate for detecting invasive infection. When indicated, analysis of burn wound biopsies through quantitative bacteriology has to be done, which improves the management and outcomes. Blood cultures have also been shown to be a late sign of invasive burn wound infection. What are the guidelines for the wound surveillance? Early culture should be negative or have low counts of sensitive gram-positive organisms. Positive cultures or high counts suggest early contamination of the burn wound. Increasing colony counts may indicate a need to change the topical antimicrobial agents. Operative wound colony counts of more than 10 to the power of 6 suggest a high risk of infectious complications and probably graft failure. Routine culturing and identification of colonization may aid in empiric antimicrobial agent coverage if the patient subsequently becomes ill. Not all organisms are created equal. Burn wound culture aids in the evaluation of nosocomial spread of organisms and guide infection control practices in every burn center. Topical antimicrobials decreases the bacterial load, like silver dressings, Urgo AG, Acticoat, Aquacil AG, Mepilex, and others. And we are using also silver sulfurizine for regular dressings. Topical antibiotics like bacitracin, neomycin, and polymyxin B are also used. Surgical management, topical antimicrobials such as mefenate and silver sulfurizine with early excision and grafting is the treatment of choice, associated with a decline in the incidence of sepsis due to burn wound infections. Change of topical antimicrobials when indicated according to the cultures, and debridement when indicated. This is a picture of excision and autograft. Unscrupulous use of systemic antibiotics must be condemned. Burn wound is always colonized with organisms until wound closure. Colonization not eliminated by systemic antimicrobials, but rather promote emergence of resistant organism. So systemic antimicrobials indicated to treat documented infections, empirical therapy to treat fever strongly discouraged, and prophylactic only for immediate peri-op period is suggested. Rotation, the use of various topical antimicrobial preparations on a regular basis, and decreases the potential for development of antibiotic resistance. These are all the strategies to reduce the infection. This is a very dry and boring topic, infection and burns. I've tried to make it simple and cover the topic in the given 10 minutes. I hope I've kept the timing. Thank you.
Thank you very much, Dr. SMITHA, for your very interesting presentation. I know that sometimes infection can be a bit boring, but I can guarantee that your presentation wasn't boring at all. Thanks for your great information. I would like to remind everybody, the people who has just joined us, that this webinar is being done under the auspices of the Learn Academy of India, reminding the aim of the academy that it is there to promote and disseminate knowledge of burns management and prevention. And we thank you all for all the great work you guys do all over with our patients over there in your great part of the world. So without further ado, we need to move on to the second speaker. As we said, we will have the Q&A at the end. Our second speaker is Professor BOOPATHY, and I would like to give you now the microphone to give us your presentation. Thank you.
Yes. Good evening to all. Greetings from Common Stanley Medical College. Sincere thanks to our Nabicon chairman, Dr. Uppal, what is kind introduction. My topic is
excuse me, Dr. BOOPATHY.
Yes.
Professor BOOPATHY, if you can move the microphone closer because we can't hear you very clearly, please.
And is a highly specialized organ displayed by third eye, which mainly dedicated structure. 40% of the patients who need surgical treatment in the initial period need secondary procedures to automate the hand function. Hand accounts for nearly 3% of the total body surface area, but 80% of the survival of the burns patient needs surgical correction of the hand. The severity depends upon the etiological agent and depth of the burn involvement. The challenges we face are inadequate initial management, improper course of procedure, and poor rehabilitation leads to a poor burn delay, results in the badly or deformed hand with a severe contraction. Difficult, but our aim is to achieve maximum function outcome. Post-burn frequently has the hand results in social stigma to the individual, to the relative, and to society. lowering of the active of the daily living, loss of income, needs multi-stage treatment, further burdens the financial status. The main pathology is with presence of hand quite opposite to the ideal and functional position. This is because patients keep their hand in position of comfort during the initial period. As soon as the patient comes to our department, we have elicited the thorough history elicitation, duration of the problem, and associated comorbid conditions, and comprehensive hand examination carried out, especially listen to the scar quality and the extent, amount of deformities present, movements of the each joint, include passive and active movements, also assess the vascular status with handheld Doppler. X-ray has been taken to find out the bony problem. With proper counseling, get the anesthetic assessment, we proceed the further course of action. The main problems with broken and deformities are either due to hypertrophic scar or contracture. Contracture produces great functional problems. Then when scar equilibrium is obtained, usually in 3 to 6 months. The recurrences are less common. We do the reconstructive procedure from proximal to distal joints. Some cases we do in stage procedure. Most of our patients are belongs to grade 3 and grade 4 of mechanic classification. So, I would like to emphasize all release the incisional release of the scar at each joint level to allow for maximum restoration of a movement, excisional removal of hypertrophic scar when visible, restoration of transition or longitudinal arches whenever necessary, release or lengthening of the deep tissue contracture like lateral band, collateral ligaments, and stabilization of the bones and joints in functional position with hair wire, resurfacing the hand and digits with thin, pliable, accessible tissue. Flaps were used for reconstruction of breastplates and other areas. Common techniques, even though excision primary closure is advisable, we are not met even single case the excision of primary closure. Most of the cases are reconstructed by either skin flap or flap cover. Local, regional, distant skin flaps are used to cover the exposed bone and neurovascular bundle. One of the advantages, early secondary reconstruction of tendon now is possible with flap cover. Here we can see the unstable scar due to burn injury, reconstruction with local transposition flap. Suppose linear contracture band can be reconstructed with Z plastic, either single or multiple. This joint, local regional flaps can be utilized for reconstruction of the corresponding areas, like crossing the flaps, posterior interosseous flaps, reverse digital artery flaps, first and secondary dorsal metatarsus artery flaps. Always produces chronocyte morbidity, sacrifices a major and minor blood vessels. Drawing flaps is workhorse flapping and reconstruction in our department. Second, abdominal flaps. They are safe flaps used for entire hand that includes volar, dorsum, and web creation. No recurrent contracture with flap cover do not compromise vascularity of hand. Recurrent surgeries are possible. One of the problems is with bulky, multiple procedures is warranted for filling of the procedure. We use free radial forearm flap or lateral arm flap for reconstruction option as a free flap. Flexion contraction of the wrist to increase the gripping power. A wrist should be kept in 30-degree extension. We can achieve by the releasing of the flexor retinaculum and the tenodesis and tendon release by or some cases need tendon lengthening by Z-plasty. All addition should be released and then adequate durable flap cover to reconstruct the soft tissue defect. MPP joint contracture, Most commonly, extension contracture is more common. Problem with the management or reconstruction of the MCP joint contracted collateral ligament, and especially up. Base of the PCH is slight over to the metacarpal shape. So, to overcome this, capsulotomy to be done to the appropriate case, release of addition on polar side, collateral ligament release, and other options. Our motto is to provide functional MCP joint and good first space. MCP joint movements, full movements can be achieved by first release the dorsal capsule of the joint, then, if necessary, divide the collateral ligament from the origin of the metacarpal head.
Excuse me, Professor Boopathy.
Yes,
The audio is still not clear, and the attendees are asking if maybe you can remove the headphones, because then the mic would be more clear.
Now able to audible, sir?
It's much better. Thank you very much.
No, thank you, sir.
Yeah.
Sorry for the inconvenience.
Yeah, no problem at all. Don't worry. Can you please give us just a very short summary for people who could not hear about the previous slides that you talked about? Just a short summary, if you don't mind. You don't need to go through the slides. Just give us a short summary of what we talked about.
Okay. Post-burn sequelae of the hand results in social stigma. Activities of daily living is lowered, loss of income, and prolonged treatment. Main problem is with the hand is held in the opposite to ideal and functional position. As soon as the patient came to our department for correction, we elicit the proper history taking, assessing the duration of the injury, comorbid conditions, and pre-operative surgical procedure history. Then examine the hand in thoroughly, but particularly attention should be given to the burn site, scar quality, and extent. Deformities present and should be recorded. Active and passive movements of each joint is assessed. Vascular status is assessed with Doppler scan, X-ray of the hand, and pre-anesthetic evaluation, proper counseling before undergoing any reconstructive procedure. Most of the problems is with hypertrophic scar formation or joint contracture. Joint contracture is produces more functional problems. Reconstruction is done within 3 to 6 months period. Recurrence are less common, done from proximal to distal joints. Most of our patients are belongs to grade 3 and grade 4 McAleese classification, needs early changes in normal architecture of the joint. So in this case, I like to do incisional release of the scar at each joint level to allow for maximum restoration of movements, excisional removal of hypertrophic scar when feasible, restoration of transverse and longitudinal hand arches if necessary, release or lengthening of deep tissue contracture like extensor tendon, lateral bands, or collateral band ligament. Then stabilization of the bone and joints in functional position, internal KOLs, by internal KOS, resurfacing the hand and digit with thin, pliable, acceptable tissue. Use of flaps whenever feasible for reconstruction of web space or other areas. Common technique used for reconstruction in our department is skin grafting and flap cover. Local flaps, regional distant flaps, free flaps are used to cover the exposed bone, tendon, neurovascular bundle, especially in cases of deep burns, that is 3rd to 4th degree. Flap cover helps to do the secondary reconstructive procedure of tendon nerve fiber, nerve sheath, nerves. Types of flaps can be a scar-based flap, local transmission flap, or advancement flap. Here we can see the unstable scar involving the IP joint of thumb. Here we do the excision of the unstable scar and cover with local transposition flap. Regional flaps, able to see the radial, pedicled radial forearm flap. Most of the cases, nowadays we use posterior interosseous artery flap, first and second dorsal metacarpal artery flaps according to the need. Problem is downstream morbidity sacrifices a major and minor blood vessels. Groin flap, work as flap in and reconstruction in our department. Then comes abdominal flap. Both are safe flaps used for entire hand site. That is volar, dorsum, and web creations. Recurrent contracture is not occurred with the flap cover. Should not compromise the vascularity of the hand. One of the major problems is bulky, needs multiple procedures for thinning. Free flaps, free radial forearm flap and lateral arm flaps we usually used for reconstruction of the hand defect. Flexion contraction of the wrist. Gripping power is increased by extend the wrist to 30 degrees. It is achieved by release of the flexor retinaculum. Then assess the movement of the tendon. If not, then tendon lengthening procedure by Z-plasty. In some cases, we may release the severe the tendon. Then durable cover to protect the tendons and median covered with flaps. MG metacarpophalangeal joint contracture, most commonly extensor contracture is present. Contracted collateral ligaments, especially with the first base of the proximal phalanx to slide over the metacarpal head with the first finger. It is addressed by capsulotomy, release of adhesion on polar side, collateral ligament release, and other soft tissue release of MCP. MCP joint adequate function is established by the excision of the dorsal capsule. If necessary, divide the collateral ligaments from the origin of the metacarpal head, then cover with ideal flap cover. Here, 2 years old baby is presented with flexion contracture of the MCP joint, release, incisional release, then stabilization with the K-wire, covered with groin flap, final outcome. Proximal interphalangeal joint flexion contracture, adequate release is achieved by the incision of the volar plate from the periosteum up to the joint base level. In chronic proximal interphalangeal joint contraction leads to botanist deformity, flexion at PIP joint and extension at DIP joint. If deformity passively correctable, treated by splinting, and if skin is normal, reconstructive surgeries. If skin is bad and deformity is resistant passively, we do orthodesis. Main goal is to achieve stable fingers with pulp to pulp contact with thumb. We can see the contracture release and covered with SSG. DIP joint contracture, most commonly flexion contracture, results in mallet finger, usually due to poor quality of skin. Orthodesis we done at with 0 to 5 degree flexion. Web space problems is reconstructed with first dorsal interosseous muscle interosseous release. Some cases, adductor polycis origin release. We can achieve adequate web space creation and cover with posterior interosseous artery flap or groin flap. Hand like this, even first web space reconstruction is done with SSG, thick SSG. Volar contracture, we must take care of the neurovascular bundle and its limiting factor in release. Most commonly, little finger is affected. Usually requires full thickness SSG for smaller areas. Some cases needs amputation because of the high tension electrical burns or circumferential flame burns with poor management. That cases may need phalangealization, distraction lengthening, or osteoplastic thumb reconstruction, second toe transfer. One of our cases underwent hand transplant from the brain dead patient. Here, one of the case with a young fellow to create the second pole of the hand, a second pole transfer is executed. As one of the scientists said, surpassing current benchmark constantly by continuously challenging our ability and skills to take the organization to a greater height. 2 years back, our department has executed bilateral and transplantation from the brain dead patient. Mr. Narayanasamy, 27 years male, sustained high tension electrical burns injury. Donor hand is available. Our department has performed bilateral and transplantation from the brain dead patient with success, great success. Patient is in rehabilitation procedure and time. Our team executed in this procedure. Later, early rehabilitation procedure time. Now he can be able to do domestic work. Basically, he is an agriculturalist. Now he can ride a bike. Thanks to our entire team of Stanley Medical College team, especially Dr. Jayakumar and Satish Kumar. Any success rate depends upon the proper postoperative management, includes proper rehabilitation with positioning and maintenance of the splint. Our orthotists attached with our department do marvelous job to minimize the recurrence rate of hand reconstruction with silicone impregnated or custom-made garments like this. With adequate occupational therapists to give person-oriented occupational therapy. My presentation is based on the nearly 100 cases underwent surgery during 2 years period. MCP joint, IP joint involvement is more compared with other joint exposure. Flap is the first line of management with our institution, involves reconstruction done with 64% of the cases. Conclude, and is a complex anatomical organ. Thorough clinical examination is important. Detailed assessment of the injured hand, proper pre-op planning, adequate surgical recreation of the true defect. If necessary, do capsulotomy, collateral ligament and polar plate release, appropriate reconstruction modality, proper postoperative care, adequate rehabilitation and follow-up, judicious mobilization of the joint, result in good functional hand. My sincere thanks and acknowledgement to all my colleagues for doing wonderful service in hand reconstructive surgery. To conclude, my sincere thanks to our NABI President Uppal sir and happy Guru Purnima wishes to all of my colleagues. Thank you.
Thank you so much, Dr. Boopathy, for that brilliant presentation. From my side and from the side of anybody who's hearing you, thank you all for all the great work you do with our patients. And as you said, also thank you to the Burns Academy of India for hosting this session, so that we can see all the great work that you guys are doing over there. Really, congratulations. We move on now to the last presentation of the evening. So Dr. NELLAIAPPAR, I give you over the microphone and please share your presentation with us.
Yes. Good evening. Good evening to Professor Uppal and Mr. Emilio Gallia and my colleague speakers and to the listeners. So my topic is a very wide topic, like a ocean, reconstruction of the post-burn head and neck surgery is really an ocean. So in order to minimize or in order to reduce constraint with that time, I'm just going to deal more on the neck as well as the scalp reconstruction. It is unfortunate that face, which is supposed to be a seat of happiness and one's own identity, is being injured during a burns injury, either the flame burns or chemical burns like acid, or also with electrical burns, and so many ways. So it is unfortunate to have the burns victim to have the psychological destabilization because of their facial attack. So as a plastic surgeon, as a burn surgeon, when these type of patients are coming and consulting with you, so our aim, our goal should be to have an early wound re-epithelialization and minimize the functional sequelae as well as to preserve the aesthetic landmarks. These are the important goals. So to achieve these goals, we must follow certain treatment principles. The most important is depending upon the depth of the injury, our treatment varies. In epidermal and superficial partial thickness burns, normally we expect spontaneous healing. Sometimes it is little augmented with dressings like collagen and Urgo AG and other biological dressings are available. In intermediate or intermittent thickness of burns, only experience tell you whether to do the going for the primary treatment or just to again put it in conservative management and go for the surgery later. This only experience itself and no definite investigations can reveal about these things. The third category, deep or full thickness burns, we can surely go for early excision of the burns and the burn wound with coverage, with a resurfacing, with a graft or with a flap, according to the possibilities. So after the surgeries, how we are going to, in general, for all any type of facial or neck wound managements, we are going for the post-burn rehabilitations. Number one is the splintage. As already told my professor, head of the department, Professor BOOPATHY, we have got a very good orthotic and physical medicine department would help and in all those things. Splintage they apply, and physiotherapy is more important. Scar massage will definitely reduce the scar contractures, and compression garments either with the silicone or without silicone. Silicone gel sheets definitely have play a very big role in reducing the scar as well as other sequelae like contraction and other things. So here is this patient who are having a epidermal and superficial partial thickness burn, which were healed by itself without application of anything else. This one is the deeper second degree burns, and of course, no burn will be uniformly super second degree. There may be associated superficial burns also, for which we have applied for the collagen and the wound healed after 2 weeks. This one is the deep partial thickness and full thickness burns. So, deep partial thickness and full thickness burns, where the wound is healed with a skin grafting, and sometimes other complications like hypertrophy scars and contractures were started in this type of burns. So when are you going to reconstruction, when are you going to start the reconstruction, depend upon the anatomic location and severity of the burns and limitation of the range of movements. Early intervention for neck, eyelids, perioral are suggested, because especially the neck, you have to do it to treat the other conditions also. And otherwise, neck, if you leave it in a later stage, what would happen? It became a severe contracture, and it will face a very big problem for the anesthetist to give anesthesia. So neck always given preferences to make future induction of anesthesia easy. So presentation to surgeon, scarring with issues of pigmentation is more important, but it can be prevented if the patients are coming after healing. We can suggest for a sunscreen lotion and asking to avoid sunlight exposure. With all those things, we can try to prevent those pigmentations. And hypertrophy causes, that also I have told, with hypertrophy scar massage and application of silicone gel sheets and other things can really reduce the hypertrophy scars. And tight scarring of the face, they may involve the dynamic of the face also. So adynamic face will be resultant, which is aesthetically more important to correct this, so that patient can have the expression afterwards. Scarring with contractures with the functional and non-functional problems also important. So how we are going to deal with the neck burns. So goals of treatment are postponed scared contracts of the neck to provide stable soft tissue coverage, because as you know, neck is also important. That transmit important vessels and nerves from the tongue to the skull. So that this area to be given coverage should be very adequate to correct facial deformities. So neck contraction result in the lower 1/3 of the face also, which will pull the lower lip and the other face. So that is also to be corrected. Retain range of movement to normal, because human will be very happy in having the full neck movements, both flexion, extension, and lateral flexion, as well as rotation of the skull should be normal. Reconstruct the cervical mental angle, which gives a beauty for anybody else. So improve vision and satisfactory forward gaze, that is more important. Otherwise, so how we are going to classify the neck contractures? Neck contractures as per the symptoms and to the limitation of movements, we are normally classifying into 4 grades. The grade 1, they are symptomatic, but they can extend the neck fully, but with a little discomfort. So there is no limitation range of movements, no facial distortion, but mild symptoms will be there in grade 1. In grade 2, they are symptomatic, mild limitation in the neck extension, distortion of the lower 1/3 of the face version. They can extend, but not the full skull extension will not be there. Grade 3, they are also symptomatic, cannot extend head past neutral position. Then distortion of the lower 1/3 of face must be there. Grade 4, they are also symptomatic, loss of cervicomental angle, severe facial distortion, and mentosternal adhesions will be present. So as I told earlier, an anesthesia, the latest thing, fiber optic endoscope is the safest method, but in many centers it is available. Some centers may not be available. In that case, normally we give 2% over the beneath the scalp, and 2% anesthesia, local anesthesia may be added with IV ketamine. Then we are starting intubations. So surgical planning, what lines of contraction and proposed incision marks preoperatively, calculate amount of soft tissue coverage required. Sometimes in a severe burns injury, there may be lack of donor site present. So you have to plan it well before. The reference points like mental tubercles, NL knots, midclavicular point, mandibular angle to be mentioned. Then incisional and excisional release should be there. So extent of release from one neutral line to another. From that, fishtailing at the ends, depth we can go up to platysma, even below the platysma, supraplatysmal deeper is also. Apply unmeshed horizontal sheets of graft to achieve the aesthetic look. The diode dressing is applied after the grafting. This is our first case. This is also a grade 4 contracture neck. We do the Y local excision. We can appreciate the real expected defect with the apparent defect. The apparent defect is very minimum. Real defect is so huge. So we did the grafting, skin grafting over that, harvested from the thigh for the patient. On the 10th post-op day, the later post-op day, it went well. Patient achieved 100% movement in the neck. This is one more case of class 4 this thing. For this patient, also with the same thing. So neck extension is fully achievable, range of movement is fully seen, as well as the cosmetic looks also patient achieved. Sometimes what is the disadvantage with the graft resurfacing? It may go for again recontraction. Patient has to go for another surgery. So in order to prevent that, and moreover, if it is a very smaller size scab, small to medium size scab in the neck, then we go for a supraclavicular flap or cervicohumeral flap, or deltopectoral flaps. Other thing like free flaps and tissue expanders also has a role in that. These patients contracture, when compared to the previous 2 patients, it is very minimum only. So we took a supraclavicular flap, and that was a resurface neck. Here also one more case. This is on the left side. We took the supraclavicular flap and resurface. Patient went well. So any neck contraction management, the post-operative management is more essential. It should be always nursed in supine position. Neck is maintained in extension of the shoulder support. After 3 weeks, active and resistive dynamic and static self-exertion will begin. Splintage for 4 to 6 months, one graft settles. For some people, even we are prescribing for 1 year also, or otherwise recontraction will easily go for. Splintage not required if flaps are used. The early managements, we can start orals in the second day itself. No need to put the rails tube and all. There we are not doing in our department. So next important organ for the scalp. So scalp in the post-burn contractures, the post-burn sequelae, we have the minor to major types of alopecias. Scalp involvement is normally 25% in the facial burns. So we are using the following reconstructing methods to alleviate this problem. One is serial excision, that everybody else knows about that. That is for a smaller allopatic area, we can do that. Another one is the local flaps. Either we can do a transposition flap as a rotation flap. Sometimes very small scale areas, we can go for hair transplantation also, like FUT, FU can be advised. Tissue expansion also they clone. Very rarely microvascular free tissue transfers like free LD flaps are also done. This is a case of electrical burn surgery with Urgo. After the development, the entire calvarium is exposed, part of the calvarium is exposed, and healthy tissues are totally excised. This results in such a big area. We planned for a local transposition flap that is covered. The donor site was covered with skin graft. It's a 10th BOD. If the patient wishes to have hair-bearing skin in the donor state also, as a second stage procedure, we can go ahead with the tissue expander, and that can be also covered. This is a huge area post-burn alopecia. For the patient, excision is not possible. On such a big area, doing for FU or FUT is also a difficult procedure. We explain the patient, and tissue expander was applied. In the first sitting, we had half of this scar was excised and was covered with a hair-bearing scalp. And we are planning for the rest of the half as a second stitching. Another soft tissues involving the area in the burns is eyelids and periorbital region. They are mostly in the critical burns. So ophthalmic injury, the facial burn occurs in different studies from 4% to 36%, 13% as a corneal injury also. So once these lids are injured, the complications are conjunctival exposure, excessive tearing, exposure characteristics, and corneal ulcerations. So principles for release of lid ectropion. So before doing all those things, we can do a temporary toxography also, many centers to predict the corneas. The release of ectropion, do not treat both lids simultaneously, operate one side at a time, keep a low threshold for release. Full aesthetic subunit should be covered. Any facial wound, we always consider about the aesthetic subunits. We normally take the subunit as one single unit and treat the patients. Always overcorrect. Release incisions should extend from medial to lateral canthus. Upper eyelid, normally we use intermediate or thick STSCs. The lower eyelid, full thickness skin grafting we are doing. Upper eyelid is mobile. SEG will contract, FTG will cause ptosis. Hence, intermediate STSC is preferred in the upper eyelid. This is the case. We have ectropion in the left lower eyelid. The scar tissue was excised, ectropion was released, and a simple rotation flap from the adjacent skin helped, and the problem was solved. In eyebrows, loss causes dramatic change in facial features. To restore normal appearance of eyebrow is very difficult, hence conservative management is preferred. Should never be excised in acute stage, as regrowth can occur with some of the post-burn area. If it's a permanent thing is there, then you can go for either hair grafting or superficial temporal artery island flap. Subcutaneous island pedicle flap is also used to cover the eyebrow reconstruction. Extensible discharging the eyebrow, release of scar tissue and Z-plastic. Yes, these are all, when become complicated, you need a composite reconstruction. The nose also similarly is a very aesthetic pleasing nose, has a projection. Does it functional stop of breathing also taken care during reconstruction. Cheek, the primary closure and serial excision, there is a minimal scar is present over there. Major scar, when go for skin grafting, like tissue expansion also can be applied the nearby normal tissues and can be transposed over there. Very rarely, flap cover is also. So principles while planning reconstruction of the cheek is that you should be kept in mind always. 1/3 of the cheek needs reconstruction. Concerned area should be replaced from cervicofacial flaps, etc. More than half of the cheek needs reconstruction. Then entire aesthetic units to be replaced. Lip and perioral region, most common reason for microstomia is electric burns in children due to biting of live electric wires. The commissure injury is there. Oral commissure should be positioned at mid-pupillary line. Splints are important to avoid microstomia. Thank you very much for your patient listening. As time constraint, I'm finishing with this. Thank you.
Thank you very much, Professor, for your very, very interesting presentation that you gave us. As we said in the beginning, because of time, we will not be able to take all the questions. However, if you have registered your email when you registered for the webinar, we will send you the questions during the answers to the questions during this week. But however, we will still have some time for a little bit of discussion. So the first question that I would like to put to Professor BOOPATHY, it was from Sadia Rashid. The question is, early tangential excision is applicable for how many TBSA at a time? And how many sessions can be done with duration or gap between tangential excision?
Hello.
Yes. Prof. BOOPATHY, you are on mute. Maybe we have some problems with connectivity with Professor BOOPATHY. There you go.
This.
Hello.
Yes.
Hello. My topic is regarding the hand burn sequelae and reconstruction. Even though early tangential excision is applicable up to 10, we are doing up to 10% of the body surface area, especially over the hand, dorsum of the hand. Duration. Our experience is only limited. Up to 10% of the body surface area, we are doing tangential excision and covers.
Thank you. There's another question here. Maybe both the professors and maybe even the chairperson, Professor Uppal, can give us some of his experience. A question on how to treat unstable scars in early recovery period.
Unstable scar is always unstable. So always no role of early recovery period. We do excision and provide durable cover.
Yeah. Do you want to add anything to that, Professor Uppal and Professor NELLAIAPPAR?
Yeah, I think the early excision, the limit is almost 20% plus. And at certain centers, it is up to 30% they remove. The only thing is that how to give a cover to that much area. So if you have you see opportunity, or if you have a service by a kind of skin bank backing up, maybe you can remove up to 20 to 25% at one sitting. Now, of course, you need to have a good blood bank backing up and a good team to do that excision and the dressings. More so, if it is on the limbs, then the limit can be more. So different experience by different surgeons and different centers as such.
Professor NELLAIAPPAR?
Yes, if the scar depend upon the size of the scar, early scar. Normally, in small to medium-sized scar, we try to apply pressure garments with silicone gel sheets applications. And if possible, if the patient is fit enough, we can also do the intralesional kinocort injection also given in our center, sir. We observe for the scar maturity and other things. And if it is not amenable for this type of conservative managements, then we are going for scar excision and other graftings.
Thank you very much for your answers. I would like to draw the attention of the participants that unfortunately Dr. SMITHA had to leave for a very important meeting. However, the questions that were directed to her, we will send as well. So another question to our esteemed professors who are with us. The question here is from Sadia Rashid. Scar equilibrium will be achieved at 3 to 6 months. Joint fusion also takes place approximately 6 months. To avoid this, can we perform contracture release early in special cases?
Definitely, sir. Definitely. We can do early intervention and do the necessary contracture release and reconstruction option. It is not mandatory. We have to wait for 6 months. We can do much earlier also, sir. Depends upon the needs and requirements of the patient and the area involved.
Professor Uppal and NELLAIAPPAR, do you want to add anything to that?
Usually they say that the contracture matures at 6 months. That is the usual thing, but there is no way it's not mandatory that we cannot do it earlier. If the contracture is, you see the functionality of the limb is very much hindered. Suppose a hand contractures, the daily kind of rituals or daily kind of work is not being done by the patient and he or she is in real trouble. So you can go anytime probably. The only thing is that it might get contraction again and there may be a contraction later on because many of our patients, they will get the contracture release, the grafting is done and they go home and then they get neglected because they do not undergo the required physiotherapy, do not apply the required splintage and do not apply the emollients or the kind of creams which are prescribed to them and they just go home and relax. So they get the contracture again. So I think if we operate early by means if there is a compulsion, then the follow-up treatment should be more vigorous. The physiotherapy, the application of the moisturizers and night splinting or whatever splint has been prescribed. That much it has to be done. Otherwise, the normal contention is that you wait for 6 months, put the patient on physiotherapy and then do the contracture release.
It's when the scar involves with a range of movements, when it reduces, then we are also doing early excision and surgery cover. Surgery covers we are doing.
Yeah, I think in this time we have to end with a question here that is very interesting. It was forwarded to Dr. NELLAIAPPAR, but definitely our 3 esteemed professors can give us their insight here. The interesting question is, how did COVID-19 pandemic change burn surgeries and burn management?
Yes.
The only thing, sir, during this COVID time, people are afraid to see patients as they will also incur infections, sir. But that was the initial period, sir. Now with our experience, even with the burns patient, whosoever is coming in any of the private hospitals or in government hospitals, we test COVID test, sir. If it is found to be negative, we start the normal treatments. As usual, we are treating the patients.
Fantastic.
Yeah, definitely. Definitely the COVID has affected the kind of planned surgeries. Like we were talking about contractions, and we would wish that those patients who want to get it done, they are thoroughly checked for the test is done, the COVID testing is done. A day before they are admitted and COVID testing is done, the report comes positive or negative. If it is positive, then of course the planned surgery is deferred. Because it has been seen that the surgery done in a COVID patient where it is planned surgery, there is a lot of flare up in COVID kind of manifestations in 3-4 days time. So the caution is, if the patient is positive and he wants to go for a planned surgery, preferably don't do it. If it is an emergency, then suppose there is a burn patient who comes to the unit, we need to attend them, then treat him as positive. Take all precautions, take level 3 prevention kits, wear all PPEs, take care of your staff, tell them, be confident that they also wear the level 3 PPEs, and then send the kind of testing by next day. Because if you send it in the morning, by now the PCR tests come by evening, and there is a rapid test now available which gives you a positive report. There's nothing like negative in that. If it is patient is positive, it gives a positive report within 3 to 4 hours. So take all precautions, and till the negative report comes, treat all patients as positive and take all PPEs, level 3 PPEs. So that is a request. Don't reach out without masks, without your suits and all to the patients.
Okay. So I think we have exceeded more than our time. I would wish that we could spend all the evening together here because of the interesting interventions that we had. Thank you very much for the people that have joined us. As I said, we will try to send to those who put their email in the registration the answers to the questions. So what I would like to do now is to have a last statement from Professor NELLAIAPPAR and Professor BOOPATHY, and then the closure of the webinar to the professor of the the president of the National Association of Burns India, Professor Uppal. And from Urgo Medical side, we thank you very much for this amazing webinars that we are having together. So Professor BOOPATHY, then Professor NELLAIAPPAR, and sorry for the pronunciations, and then the closure by Professor Uppal. Professor BOOPATHY?
Yes, sir.
Just a parting statement to our attendees.
No, nothing to. My sincere thanks to, once again, my sincere thanks to our beloved President, Dr. Professor Uppal, and Urgo Medicals to provide this excellent opportunity to share our experience with all over the world. Thank you, sir.
Thank you very much, Professor NELLAIAPPAR. And sorry, Professor NELLAIAPPAR, if I haven't pronounced your name very well, but
Me also, thank you very much, sir, for the National Academy of Burns and Professor Uppal for giving this opportunity to talk with fellow surgeons of our throat country and other my friends from UK, Dr. Shankar, cosmetics. He was also watching. I could be able to see all those friends. And this discussion was really wonderful. So many participants were there. Certain questions I was studied. I will answer them through mail, as you said, for them. So thanks for everybody else, and for Urgo Medical, especially thanks for arranging this webinar, sir. Thank you very much, sir. Thank you.
Thank you very much. From my side, I thank you both, and my sincere thanks again to Professor Uppal, President of the National Burns Association for Burns in India. Your parting statement for our participants, please.
Yes. So at the outset, I'm really thankful for Urgo Medical for sponsoring and making this academic feast possible. And I wish to thank all the three learned speakers from our country who have given a beautiful presentations, though the time was limited, and we wish that we continued. And I wish to thank, because without delegates or without participants, it's of no value. So we have participants like from US, the Burn Reconstruction Association's president, Dr. Mark Fisher was there, Carlos was there, Dr. Carlos, and lot many people from other countries joined in this presentation. So the National Academy of Burns feels proud to have every one of you participating and wish to have more such academic programs in future. Thank you very much.
Thank you very much. And hope we will wait for the next association webinar, waiting eagerly to see the experiences that that you are having in India to share with the world. Thank you very much, everybody. Be safe and take care of yourselves, and have a good night.